All right, let's jump right in. We're going to break down ventricular tachyarrhythmias from a pharmacist's point of view. Think of this as your quick guide to medication management and, just as importantly, patient counseling.
Okay, so here's our game plan. We'll start with the basics. What are VT and VF? Then we'll get into the strategy, our goals and choices. After that, we'll hit the pharmacy focus, the key drugs you'll see. We'll spend some time on a really critical risk, QT prolongation, and then wrap it all up with practical counseling points you can use right away.
All right, first things first. We gotta get our definition straight. What exactly are we dealing with? Understanding the difference between VT and VF it's the foundation for everything else we're gonna talk about. So, ventricular tachycardia, or VT. This is when you've got at least 3 consecutive beats coming from the ventricles, firing off at over 100 beats per minute. Now, this is a tricky one in practice, right? Because for one patient, it might be a total non-issue, something you just happen to see on a monitor. But for another, it's a full-blown life-threatening emergency. Now, ventricular fibrillation, or VF, this is a whole different beast. It's not a fast rhythm. It's just pure electrical chaos. There are no real QRS complexes. The heart is basically just quivering. It's not pumping anything. This is cardiac arrest, and it's why you see them grabbing the paddles for an immediate shock. Without that, there's just no chance.
And this is a really important distinction you'll see in patient charts: sustained versus non-sustained VT. Think of it like a fork in the road for how we treat it. A little burst of non-sustained VT in someone with a perfectly healthy heart, often not a big deal. But you take that same little burst and put it in a patient with a weak heart, say low ejection fraction, suddenly it's a huge red flag for instability. Sustained VT, though, that's anything lasting 30 seconds or more. That pretty much always means we have to do something.
Okay, so we know what we're looking at. Now, how do we actually manage it? What's the game plan? The goals themselves are pretty straightforward, but the choices we make, well, that's where it gets interesting. It's all about balancing drugs and devices.
Look, our goals here are crystal clear. Goal number 1, stop the immediate danger. Get a real perfusing rhythm back online as fast as possible. Goal number 2, make sure this never, ever happens again. It really boils down to that: immediate rescue and then long-term prevention.
And this is where our role as pharmacists really comes into focus. Let's be clear. For secondary prevention, devices, those implanted cardioverter defibrillators, or ICDs, they are the gold standard. They're the ones that save lives. So where do our drugs fit in? Think of them as the crucial supporting actors. Their job is to prevent the arrhythmia from even starting, and, this is a big one for quality of life, to cut down on the number of painful shocks a patient gets from their ICD.
All right, let's get to the part we live and breathe: the drugs. This is our pharmacy focus. We're going to look at the key players you'll be dispensing, checking, and counseling on day in and day out.
But wait, before we even touch the big gun antiarrhythmics, we have to talk about this. This is so important. The guidelines are super clear. Beta blockers are foundational. If a patient can tolerate it, they should be on one. For almost every single one of these patients, you should expect to see a beta blocker on their med list. It's the bedrock of therapy.
Okay, so this table really lays out our toolbox. You've got your beta blockers, metoprolol, bisoprolol. Again, these are foundational. Then you've got the class 3 agents. Amiodarone, man, this is probably our most effective drug, but it's a beast, right? Super long half-life and a side effect profile that reads like a textbook. It can hit the thyroid, the lungs, the eyes, you name it. Then there's sotalol. It's kind of a 2-for-1 with beta-blocking properties. The big thing to watch with sotalol, that pro-arrhythmic risk, the risk of torsades goes up with the dose and, crucially, if the patient's kidneys aren't working well.
And here's a really interesting paradox with amiodarone. It's a classic exam question, right? It always prolongs the QT interval. I mean, you look at the ECG and you'd think, whoa, red flag. But here's the crazy part. The actual real-world risk of it causing torsades de pointes is surprisingly low. Way lower than other drugs that stretch out the QT.
Okay, so speaking of QT prolongation, let's really dive into this. This is probably the single most critical risk that we as pharmacists need to be on top of. We're talking about drug-induced QT prolongation and its scary cousin, torsades de pointes. So let me ask you this. You're looking at a patient's chart, you see their ECG results. What's that magic number? What's the QTC value that should make you slam on the brakes and take a hard look at their entire med profile? The number you're looking for is 500 milliseconds. Anything over 500, or a jump of more than 60 from their baseline, that is a major red flag. That's your cue to pick up the phone, because that patient's risk for torsades is climbing, and we need to reevaluate what's going on with their meds right now. So this slide, this is basically your mental checklist every time you dispense a QT prolonging drug. You should be running through this list in your head. Are they female? Older? Bradycardic? What do their electrolytes look like? And look how these things pile up. A patient is on a loop diuretic which can tank their potassium, and both of those are separate risk factors. It's our job to spot these connections because each one adds another layer of risk.
So here's a simple workflow you can use every single day. 1. Verify. Is this drug even on the list? Check a resource like Credible Meds. 2. Review. Go through that checklist of risk factors we just talked about. 3. Assess. Is there a safer alternative we could use? 4. Dose. Always start low and go slow. And 5. Monitor. This means counseling the patient on what to watch for and maybe even checking electrolytes. This whole process, this is where we make a huge difference in patient safety.
Okay, we've covered the what and the why. Now, let's talk about the how. How do we take all this knowledge and turn it into simple, clear counseling points for our patients? This is where we can really empower them.
Let's take amiodarone, for example. Your counseling here can't just be about the heart. You have to talk about the other stuff. I mean, you've got to tell them about sun sensitivity, wear sunscreen, wear a hat, and you have to really hammer home why those regular blood tests for the thyroid and liver and those eye exams are not optional. They're absolutely critical for staying on this drug safely.
And for any patient on one of these drugs, these are the red flag symptoms they need to know. New palpitations, feeling dizzy or lightheaded, and especially fainting. We need to tell them this isn't something you wait on. You need to report this immediately. Explain to them that it could be a sign that the medicine, instead of helping, is actually causing a new dangerous rhythm. That really gets their attention.
This last point is all about being proactive. It's about connecting the dots for our patients. They might not realize that getting a bad stomach flu, with lots of vomiting and diarrhea, isn't just about feeling sick. We can explain, hey, that can throw your electrolytes out of whack, and for you, that could actually increase your risk of an arrhythmia. Same thing if they start a new water pill. We have to make those connections for them.
So, let's wrap this up with something to think about in your own practice. We've talked a lot about the dangers of torsades de pointes, and it is dangerous, but it's also pretty rare. You'll see plenty of high-risk patients on multiple QT prolonging drugs who do just fine. So that leaves us with this constant balancing act, doesn't it? How do we, as pharmacists, confidently get these necessary, life-saving drugs to our patients while still being that vigilant safety net, guarding against a risk that is rare but absolutely devastating when it happens?